Okay, hey everybody, this is part two of the vaccine hesitancy discussion. If you haven't watched part one, please close this link and watch part one first. We just talked about vaccine hesitancy as an idea. We kind of worked our way that it's not like a new idea, right? That we have vaccine hesitancy against measles vaccine MMR for a whole fraud case linking back to the 90s. We have vaccine hesitancy against the influenza vaccine, in part because of complacency, in part because of minimal effectiveness of that seasonal vaccine and some of the guesswork that goes into determining which flu strain will be circulating in the U.S. each season. All right, so this idea of vaccine hesitancy, again, as I mentioned in part one, is a complex idea. That's a lot of factors going into it. Let's look at this this snapshot here of the childhood vaccination, kind of key vaccines everyone gets in childhood. And I say everyone, but clearly not, right? So we have the diphtheria, tetanus, pertussis, or DTP or DTaP, the polio vaccine, the MMR vaccine, Haemophilus, Hep B, chickenpox, varicella, pneumococcal conjugate vaccine. All of them have varying reports of usage, right? So they're not 100% for each one of them. And the key thing is that very last bullet point. The combined 7 vaccine series was only taken up by 70.7% of children in 2017. And the data is from 2016. So why? Are there that many folks that are hesitant to receive these vaccines? Are some of these vaccines perceived as more risky than others? Looking at the individual data, so the one that gets the most noise because of that fraudulent studies from a few decades back is MMR. But you can see here from this data here, the MMR was taken at the second highest rate of completion. Right? So one of the challenges that comes up a lot is the number of doses. Right? So if you look at each of these vaccines, we see that there's 4 doses, 3 doses, 3 doses, 1 dose, 4 dose, right? And that requires people to come back to the doctor, right? It requires folks to come back and get those booster shots on a certain regimen as well. So maybe that's 6 months, maybe that's a year after the first dose. But it requires good access to pediatricians and primary care. And that's something in our country is lacking. Right? These are issues we'll kind of talk about later on in the semester with the U.S. healthcare system and some of the challenges that we face here. So access comes into play as well as hesitancy. And so when you see the combined number of 70%, only 70% of kids in 2016 getting all of those vaccinations, that's more of an access issue because there's not hesitancy against one vaccine in particular. Or we're not seeing like a average of 30% hesitancy across the board. So it really does point towards more of this access issue. All right, quick tangent. Let's look at influenza over the last couple seasons and look what's happening right now. Because I think this is a really interesting story. I'm not going to do a whole lecture on it, but I want to point your attention to it. You may have heard about this. So this data here is looking at influenza-like illness. And this is reported CDC data that you can look up as well. The dashed line is the baseline, is of how much you expect to see in a given season. If we average out the entire year, we know that flu is seasonal. So when you see weeks on the x-axis there, we're looking at the end of one year and the beginning of the next, right? So if we number our weeks like January 1st, that's the first week, right? And the end of December is week 52 there, right? So we're looking at the winter season, and that's when we have peak flu activity. What we're seeing so far in the 2020-21 season is almost no flu, like almost zero influenza being reported. Why? Here's another look at it. Here's influenza activity in 2019-2020, so last year, versus this year. This is all from the CDC. You can hit the link there to play with it. And on this map, you can actually change it by week. You can do that about every year going back and see what the kind of flu activity was looking like in that week in that particular year. Now, March, when we get into March, we start to usually hit some of this downslope, right? So depending in March, we're hitting the downslope on some of these graphs here as the flu season starts to kind of wrap up and slow down. But still, even with that, you can see that in a year like last year, there was still pretty high flu activity. We had very high or high flu activity in many states around the country. All right. This year, minimal. Everything, minimal. Some hospitals reporting that they haven't seen a case of influenza all year. What the hell's going on? All right, hey, did everybody become believers and start taking the influenza vaccine? Well, a little bit. So there's a report out, and the CDC publishes these reports, I think at least 2 to 3 times per flu season, about what does the vaccination rate look like. So the vaccination rate is higher. I showed you the one data point from a few years back that it was like a third of adults. Now we're looking like more towards half of adults, right? So maybe it's 50 to 60% of adults are reporting that they took the flu shot this season. We don't have data on efficacy yet of this season's flu shot, but it's likely that it's probably not 100% effective either, right? So there's been a little bit of bump in the uptake of the flu shot, but maybe not to explain kind of like the total eradication of influenza this season. So what's at play, right? You guessed it, right? So vaccine usage went up a little bit, but really, what is doing it? Why are we not seeing a lot of flu? Well, again, the mask usage, the social distancing. We're better at washing our hands, hopefully. Sanitizing our hands with hand sanitizer. There's been much less travel. That's been a big one, right? Domestic and international travel is a big spreader of disease, right? And flu in particular. So less travel around has been good for preventing flu. Kids are like super spreaders, right? Kids don't wash their hands. They don't wipe their hands when they sneeze into them. They often just sneeze and cough right in your face. If you have little kids or you've been around them, they're super fun. You'll get there. And so with less kids being sick because schools were closed and they're not talking to their peers as much, there's less disease being spread. And therefore, if we zip back a few of these slides, right, and look at this graph here, when this graph gets updated for 2020, 2021, it's going to be negligible. It's not even going to be a bump on the radar, right? Because of some of these measures that were put in place. Now, obviously, we're not going to stop, once the COVID pandemic is over, travel will probably go back to more sort of normal, right? We will have schools opening up. We need these things. But some things, especially during heavy flu season, might be worth exploring. This whole mask usage idea. Some of the hand washing, sanitizing, social distancing. Do we actually use some more of this to actually prevent death in our country from influenza? Not the most severe, not closing businesses, not closing schools, but are there ways in which we could take some of these measures and learn from them to prevent the illness and death that we see from flu each year? Something also to think about and reflect on. There's a good Michigan perspective story from the Detroit News, too, if you want to click on that for some further reading. What we're trying to really get at is for vaccine hesitancy with COVID. All right, so who's hesitant to get the COVID vaccine? And there's a lot of interesting stories in how it's changed over the last few months as the vaccines have started to get rolled out. You can hit those stories, NPR story, Free Press story about this. So the early story was that many Black and Latino individuals were hesitant to get the COVID vaccines. And why? A lot of that stems from the historic racial injustice in our country and the way in which the healthcare system has propagated those injustices, whether they're with biomedical research, whether it's with access to care, whether it's straight racism by providers. Right? There's a whole series of issues that are complex that contribute to why Black and Hispanic individuals may not be ready to really jump in and embark on some new medicine, right? Something new like the COVID vaccines. So that was some of the early story. However, as you can see from the title of that story there, right, that's changing. And now, when you look at now the polling and some of the access we have from looking at hospital system data of who in the hospital system is getting vaccinated and who's not, now we're seeing that there's not differences based on race and ethnicity of who's hesitant to get the COVID vaccine. Right? There's actually equal amounts between Black individuals, Caucasians, Latinx Americans, right? It's really normalized and is not segregated by race and ethnicity. The biggest one, and this was a really nice story and polling done by the Free Press has to get back to politics and the polarized nature that we have in this country. Then unfortunately we have a public health scenario that's gotten so polarized and politicized that we can see here in the graph, right? This is a bar graph looking at folks identifying as Republicans, and an equal amount at this time, and this was the polling is here, it is end of February, so it's about a month old, right? So about a month ago, this survey was conducted, and it had an equal number of Republicans saying that they would not get vaccinated as those saying that they would, right? And that's a big portion of the population. All right, so we have identified at least some groups that are hesitant at first, and hopefully that will change over time. Who's getting the COVID vaccines, right? So again, we know that like elderly were up first, and healthcare workers, folks with pre-existing conditions, and soon you all will be eligible for this, right? My age group is just moving into that bracket, and yours will be very soon as well. And so all of you will have time to consider whether or not you're going to be getting the COVID vaccine when you're eligible. You can track that rollout, right? This has been a problem, and it differs by state because each state gets to set their own rules. There's a really nice tracker on the New York Times here that I'm referencing. You can track both at the state level as well as around the world of how many vaccinations have been given out. We're going to talk more about it in our next lecture about variants and the spread of COVID and how the virus mutates, and how that how vaccinations play into that, and how hospitalizations are rising and that kind of stuff with these new variants. The quick story is we want to get everybody vaccinated and get this disease to low baseline levels, which means there's less likelihood for a new variant to escape the vaccinated population. So we want to get not only across Michigan or across the United States, this graph on the right-hand side about vaccination around the world, we need that one to keep rising exponentially and make sure that everybody around the world has access to these vaccines. All right, so what we've seen with this distribution is that the distribution has really exposed inequalities in the U.S., both in the health system and the U.S. at large. All right. So the first push, my wife is a healthcare worker. She got the COVID vaccine in December of 2020. Right. So she got the vaccine months ago. That initial push of healthcare workers left out many Black and Latinx people out of the vaccination picture. Right. Due to structural inequalities of who becomes a nurse and who becomes a physician. Right. And we know that there is a large skewing there in the healthcare population, something that we're going to be talking about more in our class. All right. Some of these issues also came up where Black, Hispanic individuals that were eligible in healthcare facilities were hesitant somewhat because they didn't see folks in their own communities being offered the vaccine. Right. There were still this fear because of the inequalities that exist in our healthcare system, and how folks were exposed to the vaccine and encouraged or not to get it initially. Now, thankfully, that is normalized, as I mentioned, and we don't see these differences by race and ethnicity. But these patterns where we have less vaccination available to folks that are Black or Hispanic really go at odds with who the virus has affected the most. All right, we'll see that data in the next slide here. And the big thing here, and there's a link there from the American Medical Association. So again, I include my links here on these topics to make sure you understand I'm not really sharing my opinions. I'm sharing with you data from national associations or the CDC. That's from the American Medical Association. The vaccine hesitancy isn't the primary barrier. Access is what matters. All right, here's the last slide here, right? This is that last piece of who has access to the vaccine and who needs access. All right, so you can pause on this slide and look at it. We're breaking down who's at more risk for COVID infection, hospitalization, and death. Right. With the very first column, we can see that American Indian, Alaska Native, non-Hispanic persons have a 2.4 increase rate in death compared to white non-Hispanic. Right. If we scroll over to Black, African American, or Hispanic, we see 1.9, 2.3 times the level of death compared to non-Hispanic white folks. Right, so we have inequalities in the system and inequalities of access to the vaccines. Let's reflect on this for this week.